This is Yellowbrick's ongoing forum that gives us the chance to get together, to explore issues in treatment, and to promote a deeper understanding of the work that we all do. I'm Bryn Jessup, and I am the Director of Family Services and Systems at Yellowbrick. Hosting colleagues and conversations is an important way that all of us at Yellowbrick can stay connected with all of you, our colleagues. Before I introduce tonight's talk, I'm pleased to give you a brief preview of coming attractions. Later this month, on May 24th, in person, we have Dr. Gary Rizzolo. He's a member of the faculty of the Chicago Psychoanalytic Institute and the current editor-in-chief of the Journal of the American Psychoanalytic Association. Dr. Rizzolo is going to offer an alternative understanding of growth and the life cycle with particular focus on treatment, one that does not necessarily entail continual regression to earlier developmental emotional templates. The last week in June, Colleagues and Conversations is excited to host in person Brad and Vanessa Kennedy, one of our close clinical partners at Driftwood Recovery Center in Austin, Texas. Brad Kennedy and Vanessa Kennedy will speak about addictions and trauma. I think that's not anything you want to miss. And finally, mark your calendars for Yellowbrick's annual conference. This is in November, on November 9th. It's an all-day conference in person here at the Rotary Building in beautiful downtown Evanston. We will be convening that conference as we usually do with Menninger, and Driftwood as well will join us. So stay tuned for further announcements about that. Finally, a couple of quick housekeeping reminders about tonight. First of all, it's helpful if you all make sure that you're muted during Dr. Leib's address. There will be time for discussion afterwards. Dr. Leib's talk is engaging and thought-provoking, so you'll want to note your questions as they occur during the talk for discussion later. You can do that in one of two ways. Feel free to send us your questions as they occur through the chat function. I'll keep track of them. Or, if you wish, during the actual discussion portion, you'll be able to ask your question directly. Just unmute yourselves and ask your question. Also, tonight's talk is being recorded, and a recording will be posted on Yellowbrick's website about a week from now. In addition, there will be a follow-up email containing relevant material mentioned in the talk. Now, I'm pleased to introduce to you Robert Leib. Dr. Leib is a clinical psychologist and one of the principal owners and clinical director of Pacific Psych Care Associates, which is a group psychotherapy practice in San Mateo, California. Dr. Leib received his PhD from the University of Pittsburgh and later served as the clinical and training director at the Sequoia Alcohol and Drug Recovery Center from 1990 to 1994. He's published a number of journal articles on topics ranging from the treatment of alcoholism to postmodern innovations in the practice of psychotherapy, on family therapy. His paper titled From Unfinished Adolescent to Young Adult, a Constructivist Control Mastery Theory Approach to the Treatment of the Emerging Adult Still Living at Home, was published at Sage Open Press in 2015 and is, of course, relevant to our talk tonight. Dr. Leib has been a guest lecturer at Stanford University's internship program and California Pacific Medical Center's training program. He's given talks to professional, legal, and lay audiences on facets of stress reduction, substance abuse treatment, couples therapy, short-term psychodynamic therapy, the treatment of adolescents, and control mastery theory. Dr. Leib works with adults, adolescents, and children and specializes in the treatment of stress-related problems, addictions, and therapy with couples and families. Happy to turn the mic over to Dr. Leib.
Okay, well, thank you, Dr. Jessup, and I also wanted to thank Yellowbrick for inviting me to have the opportunity to share some of my thoughts about treating this oftentimes challenging population of young adults. I did want to highlight as an opening remark a part of my biography, which I think is relevant, which is that I've been very lucky to be able to practice in a group practice with my best friends and my wife. And what's been so fortuitous about that for me has been that it creates a collaborative therapy system in a private practice setting. And in my experience of working with this kind of population, having a collaborative team of therapists together is really quite crucial in working with this population. The one member of my group that I've worked with most frequently on a collaborative basis with this group of people is Dr. David Auld, and David and I co-wrote this article that I'm going to be presenting today to you. We started actually working on this article many years ago, is 2010, I think, when we actually started to develop our ideas about this. And it was based on a theoretical model that I had co-developed with another colleague, Stephen Kanofsky, in which we worked to integrate control mastery theory and narrative therapy. And that article was published in the journal Psychotherapy. So I'm going to be focusing primarily on the application of that theoretical model, the integration, control mastery theory, and narrative therapy to this population of young adults. But I'm sure, like the rest of you, I haven't stayed stagnant in my work. And so over time, this started in 2010, was published in 2015. Subsequently, over time, I've been very interested in working with the models of acceptance and commitment therapy, if you're familiar with that, internal family systems, which I would imagine many of you are familiar with, since it's a Chicago-based therapy. And most recently, an excellent book, which I don't know if you're aware of, but I would highly recommend, by Goldberger and Omer, and it's called The Non-Emerging Adult. And that book really coordinates nicely with the work that we've done and extends it in some important ways. It differs from it in other ways. But as I go through this talk this evening, what I'm going to be doing is presenting the paper in some of its original form, but also some of the adaptations and extensions that I've done over the years of working with this group and with my growing interest in other therapy models. So before I start into the substance of the talk tonight, I'm going to start with some assumptions about all of you, and I hope they are correct assumptions. And that is, the first one is, I'm going to assume that people here are familiar with Arnett's developmental model of the emerging adult. So I'm not going to be talking about that at all here. And I'm going to assume that all or most of you recognize the scale and scope of this problem as it presents to us in private practice. And obviously, Yellowbrick is highly devoted in working with this population, which I'm going to call young adults with roughly the ages 18 to 30 years old, who in many ways you can see them as, if you will, dying on the vine, living at home. And my work is really focused on ones that are living at home with their parents. And we came to call this group of people unfinished adolescents. And so the work is from moving them from their being stuck in an adolescent developmental stage and how to help them move forward to a young adult or emerging adult stage. So the kinds of problems that this population presents with, again, I think will be familiar with all of you. These are unlaunched young adults that show up with drug or alcohol abuse. They show up with disordered sleep-wake cycles. They show up with internet addiction. They show up as depressed, as angry, as sometimes suicidal. And in all of the cases, though, the family system and them are quite stuck. And when they walk into the room, it's a mess. Typically, not always, but typically it's a real mess, and it's a real challenge. And so try to call on a number of different principles in understanding this group of people, in assessing this group of people, and treating this group of people. So let me give you briefly the overview of what the talk is going to be about, and then I'll get into it. So what I'm going to do in this talk first is I'm going to share the treatment model, which we call the constructivist control mastery theory, which is an integration of a psychodynamic, psychoanalytic model, control mastery, and with a postmodern sensibility, primarily based in the therapy called narrative therapy. Then I'll talk about some of the assessment processes that we use in terms of looking at how the individual is functioning and how to differentiate what is an emerging adult from an unfinished adolescent. And we'll assess also, it's important to assess how the parents are functioning as a marital team, how they're functioning in relationship to the identified patient. And we'll take into account all of that also in the context of culture as well. And I'll spend then most of the time talking tonight about how we go about applying this model and using this model with this population. And then we'll finish up with a dialogue, and we'll crowdsource it, as we like to say in Silicon Valley, so that we can all use our collective wisdom to add to our collective success with this population. So that's the overview. So let me, I know some people don't have their video on, but just a quick show of hands of people who do have their video on. People familiar at all with control mastery theory? Anybody ever even heard the term control mastery theory? Okay, so it's not, what I've noticed in my travels and training is that, the further you get from the epicenter, from where the theory was originated, the less and less people know about it. When I actually did my pre-doc internship in Chicago back in the 80s, and then Kohut was king, and everybody was talking about Kohut back then. By the time I got out to San Francisco, I mean, he was known, but he was not central on people's radar. And I think that's probably true with control mastery theory. How about narrative therapy? Do people know much about narrative therapy? Okay, well, that's traveled a little bit more because I came over from Australia, New Zealand. So it looks like that's had more legs in some ways. All right, so I'm going to get into the basics then of control mastery theory for all of you, since it's going to be relatively new for most of the people in the room here, or rooms, as I should say. So control mastery theory was originally developed by Joe Weiss and Hal Sampson. And it was based on Freud's writings towards the end of his career and his life, that basically posited that psychological problems are rooted in grim, largely unconscious beliefs that have been inferred from traumatic early experiences. So we can hear in that, if we know our sort of history of psychoanalytic therapy, Freud beginning to make a turn towards what we would call ego psychology, and this idea of beliefs now in a more contemporary way we might call schemas and cognitive therapy. So we're looking at these sort of beliefs that are operating unconsciously, and they are based in trauma. So in line with attachment theory research, control mastery theory, which actually is based on a lot of research, asserts that all children develop a set of beliefs about what is safe or unsafe ways to adapt to their family environments, while simultaneously attempting to meet important individual, personal, developmental needs and strivings. So these beliefs are what's going to work for me as a child to get along and be a part and get the attachment resources that I need in my family. And how does that coincide with what my individual, personal, developmental needs and strivings are? And through that lens, we would assert that in this population we're going to talk about specifically tonight, there's an overriding sense that it's not safe to grow up and launch into adulthood, because to do so would threaten the well-being of family members or not comply with who these kids are expected to be or needed to be in the family. So we can see that from that foundational tenet, we can see that there's an emphasis on the young adults and their motives and why they do what they do that's based on adaptations to the family. And therefore, it's based on altruistic concerns, what's going to be good for the good of them and good for their family and the family members' well-being, even if it comes at the expense of the young adult themselves or the child themselves. And that emphasis on the altruistic motives really helps situate us into a more humanistic, systemic, and non-pathologizing clinical stance, which I think is very important with this population. So the idea here is that these beliefs and the behaviors that they engender originate to be of service, to be protective of others. And as I've been learning, because I'm still learning internal family systems theory, it's very consistent with some of the tenets of that system as well, is that these protectors in the internal family system are developed with the idea being that whatever those beliefs are and those ways of operating are there to be of service for the system, even if their effect is to be maladaptive, but they become very rigid. And that is very consistent with the kind of work that I did with my patients as well. So originally these beliefs that the child holds are highly adaptive, because these beliefs direct them towards behaviors and attitudes that are going to work in their family, so they're adaptive. But these beliefs, when they're inferred from trauma, become pathogenic. They cause pathology. And here we're going to define trauma very, very loosely. And we can talk about big T or little t trauma, very loosely defined as any early experiences or set of experiences that harm the child or people that are important to the child. So they're pathogenic, meaning they cause pathology because they're inhibiting the child or the young adult in the situation we're talking about tonight from pursuing preferred goals, and they give rise to a plethora of troubling feelings and problematic behaviors and interpersonal conflicts. That's what makes them pathogenic. So they most commonly are going to occur when a child is attempting to achieve certain developmental appropriate goals and discovers that these attempts to do that are repeatedly leading to trauma to themselves or to their parents or caretaking other significant primary caretaking others and loved ones. And control mastery then talks about different types of these pathogenic beliefs. And these are types, but they're not meant to be rigidly exclusive. They're just patterns that are been observed over and over again. So one kind of pathogenic belief that they point to is called omnipotent responsibility guilt. And this involves an exaggerated sense of responsibility concern for the well-being of loved ones. The child in their egocentric state believes that it's up to them. They have an exaggerated sense of responsibility of what they do, how they operate, and how that's going to affect the parents or hurt the parents. The second kind of pathogenic belief is called separation guilt. And this is the type of belief, the category of belief, that one's separateness from the family of origin is going to cause harm, is going to hurt the people that you're separating from. Another type of belief is called survivor guilt. And that is characterized by the pathogenic belief that by pursuing normal goals and achieving success and happiness will cause others to suffer simply by comparison. And as I was preparing this talk, I was thinking of a personal example of that. When I was younger and in school, I didn't do very well in math, and I had math teachers telling me all the time that I was underfunctioning, that I was actually good at math. Why wasn't I trying more? A lot of criticism about my math deficits. And later on, I came to realize that in my family of origin, there was a story in that family that my brother, my older brother, was the one that was good at math. And I was having a lot of academic success that my brother was not having. And so in many ways, out of survivor guilt, I didn't want to be the one that was good at everything, including math. I was going to disavow that ability and basically say, that's his, that's not mine. Even though it would come at cost to my progress, it was done for altruistic reasons, unconscious altruistic reasons, because I thought if I was also successful in math, that was going to hurt him. So that's sort of a minor example, but it gives an example of what survivor guilt might be like. So these are one type of pathogenic belief origins. But another way that kids develop pathogenic beliefs is because they are compliant to the kind of treatment and the messages that they get from their parents. They believe that they deserve these treatments. They believe that they deserve these messages. And given their dependence and lack of prior experience, children are prone to believe that the treatment that they receive from their parents is deserved. So they comply with whatever it is, that view of them of being, because they believe that's the correct way to be. They believe that they deserve it. So we'll also look at compliance when we start to look at working with this population as being an important issue. And finally, pathogenic beliefs can be perpetuated over generations. As children identify unconsciously with certain behaviors and attitudes and beliefs expressed by their parents or grandparents, which are later transmitted to their own progeny. In IFS, these would be called legacy burdens that they take on from what happened, what their parents were carrying, now they're going to carry too. So these are all various ways that the child becomes encumbered by these beliefs about themselves, about the world, about what's safe, about what's not safe. They come at the cost and at odds with developing, whether it's their math abilities or growing up and becoming a fully functioning adult, in order to maintain attachment and connections. And that would all be very grim indeed, except this model, like I would say all psychotherapy models that we learn, have one element of the model is how is psychopathology formed, and the other model of the element of the model is how is it healed? How do we move beyond that, right? And so now let me turn our attention to how control mastery understands how people work in therapy and how therapy is mutative in helping people sort of be able to live preferred fully functional lives. So the word control mastery, the phrase control mastery, actually refers to this part of the theory, control and mastery. And so the control mastery further asserts that individuals come into therapy highly motivated to overcome their suffering that are derived from their pathogenic beliefs, and that they want to find ways to pursue their preferred goals. The guiding focus of the client's inherent motivation for health represents the mastery component of this plan, of this theory. It holds that in the course of therapy, clients come into therapy with an unconscious set of plans and act in planful ways to overcome and master their pathogenic beliefs. And they do this in therapy, but we also believe that they do this in their naturalistic family systems. Their young adults are doing this with their families as well. And they do this by testing. They do this not just the way we think about adolescents of testing limits, but they do it by testing to see if they act in this way, behave in that way, emote in this way, how is their environment going to respond? And is the environment going to respond by confirming that their pathogenic beliefs are real and true, and that it's not safe to do these things to pursue preferred individual goals? Or is their environment, their therapist, their family is going to respond in such a way which is going to disabuse them of these pathogenic beliefs? And so we look at how they come in and test and see that testing is a fundamental activity in and out of therapy to adapt to one's interpersonal world and to achieve personal goals. So control mastery theory says they're controlling how they're testing for the purpose of mastery, because they have to do this in a planful way in trying certain things before other things, because the deepest held pathogenic beliefs, the most seriously injurious or threatening ones, they're not going to test at first. They're going to test in other ways and move in that progression. And these tests are understood to occur in two general manners. And here I'm going to be talking about both therapy and in the family system. Okay. The first type is called, and remember, this was developed by a psychodynamic individual therapy system, model, it's called transference testing. Okay. So in the transference, the client in an unconscious fashion behaves with the therapist as he or she responded to the caretaker involved with their original traumatization that led to the formation of pathogenic beliefs. For instance, they may come in and they may be very challenging of the therapist. And this kind of challenging behavior, or conversely, they may be very deferring to the therapist. It's very case specific. That's an important part of this. So, but what they're doing, no matter how they're showing up originally, is they're testing to see, for instance, challenge. How are you going to be responding to challenging? Are you going to re-traumatize me in such a way that my parent did? Or deferring, how are you going to respond to deferring? Are you going to sort of go with that and have to be the big authority in all of this, just like my parents did? That's the test. And they're looking to see how you pass that test. But in this humanistic way, I would say, I guess this is humanistic, is that they want you to pass the test. This is not a contest of wills. They're not trying to defeat you. They really want you to pass these tests. So that's what transference testing is. The other type of testing that we see is called passive into active testing. Passive into active testing is where the client switches roles and treats the therapist or the family member in ways that they were traumatized. They're going to do to you what was done to them. Okay. In some ways, that's a safer kind of test for them because less of them is exposed that way. And they're going to see, how do you respond, or how do the parents respond to this? And the test is going to see is about Do you get traumatized during this kind of behavior, this kind of action? Can you hold on to yourself when people are treating you this way or giving you this messages about yourself? Do you show up as being sort of healthily entitled to your own well-being? And how do you do that? How do you go about that? They don't even frequently know how to do that because this original trauma occurred early in their childhood. They really are, quite ignorant about how people go about responding to that kind of treatment or those kind of messages in a healthy way. And so when we respond in those kind of ways, I guess we could say model the behaviors that they're looking to see, is it helps them overcome their beliefs by demonstrating that such treatment is not deserved and to model ways of coping with it. So in control mastery, all of this was developed and talked about in the analytic dyad. But we've taken this now and moved it into the family system and applied some of these principles in the family system. And saying that the young adult that we see coming into the office with all those problems that we described, and I described in the beginning, that you work with in your clinical practice, is coming in unconsciously with a set of pathogenic beliefs about themselves, about the world, about what's safe, what's not safe, and they are working relentlessly on disabusing themselves of these pathogenic beliefs, and they want their parents and their therapists to pass the test. Unfortunately, these parents, in these cases, routinely and unwittingly continue to fail these tests, okay? And there's reasons why they do that. Not because they're bad people, and we'll talk about that in a little bit too, but they are not able to pass this test. And so you get this solidification of this system where the pathogenic beliefs are getting increasingly entrenched over time, and the child is acting in such ways in accordance with their beliefs, which is it's not safe to launch. So they're stuck. And that is what we try to help them with. So let me take a drink of water here. Maybe I'll take any questions about control mastery theory at this point. Or I could go on. Okay, well, let me go.
I'll ask a question, Bob.
Yes.
Can you say a little bit more about how control mastery theory kind of locates the place and power of affects, as opposed to when you talk about the beliefs, part of my reaction, it's like, where's the feeling?
Yeah.
So how does that kind of get kind of embraced within the way in which you're actually working in the relationship?
Okay, that great question for many reasons, not least of which it helps me move to the next section of the paper. So thank you. But let me
happy to be a great muse.
but let me say something specifically about affect in orthodox control mastery theory. So control mastery theory, the primary affective state that is attended to, as you can hear in the nomenclature using, is guilt, right? So there's a real premium put on the affect of guilt. And some of the other affective states are seen as derivative from that affective state. I don't really subscribe to that fully. I really see other affective states as having a lot of primary power for young adults. Shame being one, fear being another one, a sense of defectiveness being another one. So I do think that control mastery theory, was quite limited in this very sort of narrow sense of both emphasizing beliefs and emphasizing the affective guilt. And that's why Steve and I together developed over time an extension of the theory, which is what this talk is about, which we called constructive control mastery theory. Okay, so let me tell you about that. So before I get into that, I have to add the next little building block of our therapy model, which is this postmodern therapy called narrative therapy, started by Michael White and David Epstein a number of years ago, which people seem to be a little bit more familiar with narrative therapy. So I'll briefly just talk about narrative therapy for people who are not that familiar with it. So narrative therapy develops for us, for me, an additional methodology of change in these family systems and with these young adults. And it's synergistic with control mastery therapy. And narrative therapy offers control mastery theory, to your point, Dr. Viner, with a new and I think more powerful root metaphor, and that is stories. So we talk more, I think more not in terms of beliefs, but I think more in terms of stories. And stories open up this very wide and rich landscape of emotion, of affect, of beliefs, of attitudes, of actions. Michael White, to quote him, said, "The narrative metaphor proposes that persons live their lives by stories, that these stories are shaping of life, and that they have real, not imagined effects, and that these stories provide the structure of life." So when we open up this system to look at stories, we open up to the role of affect as well, okay? And stories allow us to engender an attitude in the client, because it's not get too much into postmodernism and psychotherapy here, but it creates this sense of that meaning is fluid and malleable, and that there are these stories that the young adult carries, the parents carry, we carry. It's understandable that we have these stories, but they are fluid, they are malleable, and they also are co-constructed in a social field, which is helpful because that's what we're doing. We're working in a social field. I'm working in a social field, I'm not working in a biological field. So in this co-constructed stories, we allow us to bring forward all of the influence, including cultural influence, on how we story our lives. Just to offer a little postmodern joke at this point, don't hear too many of those these days. So this is how it goes. If I'm not a great joke teller, but so there's these three baseball umpires, and they're on the front porch in their rocking chairs at the old age home, probably not the right term, the assisted care facility for old baseball umpires. And the first baseball umpire, kind of the most cantankerous one, and he basically says, "You know what? There were balls and there were strikes, and I called them as they were." And the second one thinks about that, and he's a little later. He says, "You know, there were balls and there were strikes, and I called them as I saw them." And the third one, who's the lightest and happiest, says, "You know, they were just pitched balls until I said it was a ball or a strike." Right? So the idea of it is there is no inherent meaning to it. There's meaning that we construct and we perform through our actions all the time. So the aim of narrative therapy is to focus on people's unique stories.
Quantum physics approach to meaning.
It's a new, right, exactly, to meaning, to the meaning of it. They're not just, and you can see, like, when these families or young adults walk into your office, they do not have a constructive sense of the malleability and construction meaning. It's just, this is who the kid is, right? This is what it is. This is who my parents are, right? There's there is not much of a sense of I call it as I see it, or you know what, I'm making this up and we're making this up together, right? So people, when they realize that their stories are constructed in non-immutable truths, each and every action, as Jerome Bruner said, is a performance of meaning that simultaneously re-authors past experience and frames subsequent experience. So those are the two building blocks of the theoretical model that I use with this population. And now let me talk about what is constructivist control mastery theory, the model that we employ. So when a young adult or their parents or their family come in, we conceptualize that the individual, the families, are participating at any given moment in one of three storylines that they are telling to themselves, telling to each other through their words and through their actions. And we attend and track these storylines. What storyline is being enacted right now? And we attend to them and work to create conversations and interactions and stories that propel the individual and the system forward. So what are these three storylines? The first storyline we call the pathogenic story, pathogenic beliefs, the pathogenic story. And these are stories of hopelessness, of despair, of incompetence, of shame, of guilt, of all of that. And we as therapists and the family members, through our own words and our own actions and our own attitudes, when we participate in these stories, we're only confirming it. And so we are acting in what we would call an anti-plan manner, right? Because there's a planful basis to this. We're acting anti-plan during those times. But there's two other storylines. In contrast, we can participate in two other pro-plan storylines that facilitates the attainment of the client's goals. And the first of these pro-plan storylines or engagements we call the deconstructive work of psychotherapy. And the second one we term the constructive work of psychotherapy. So that is going to be, I'm going to say a little bit more about that and talk about assessment, and then get into a little bit more of the nitty-gritty here about it. Control mastery theory, looking at time, maybe I'll move this forward here. Okay, let's just move into assessment, then I'll get into the nitty-gritty about how we actually operate. So let's talk about assessment. In order to do assessment with this population, we've got to know, and again, I assumed in the beginning, everybody is familiar with Arnett's view, developmental phase of emerging adults. So in order to assess, we need a compass here in order to be able to differentiate what differentiates the emerging adult from what we call the unfinished child, or as Dolberger and Omar in their book, adult entrenched dependence is the term that they use. And the first key question, sort of the one that comes to mind most easily for all of us is, and this is for young adults that are cohabitating, is, well, sorry, I don't think this is the key question that comes to mind for everybody. It's the key question that I think I'd like for it to come to mind for everybody is the young adult living at home basically for economic reasons or for psychological reasons? Because we know now that increasingly this age range is cohabitating, right? And this is crucially important because if you treat the parental worry about their cohabiting child, who is there primarily for economic reasons, and if you treat this as as psychopathology, you're going to iatrogenically cause problems. You're going to cause family discord, heightened distress, and even more pathology in the young adult. So it's important to differentiate, is the young adult there because they're there because, they're saving money to be able to launch later on in life. That may be less of a problem now, but when we were first starting to do this work, particularly in Silicon Valley, where everybody wanted a child that was above average, and they were having kids that were not showing up that way, is that people were coming into my office like, let's fix this system. But as you'll see, the young adult was hitting a lot of other marks that was suggesting this was not about a separation, individuation, psychopathology. This was economic, and it was important to normalize it and help the family very quickly in that kind of way. Okay. Conversely, if the kid and the family is showing up who are developmentally delayed and suffering with mental health issues and involved in separation, individuation, psychopathology, and you treat this as normal, you're only going to maintain or exacerbate the problem. So that's the first cut, right? Is it psychological or is economic in nature? The second one is the one that I was going to say tends to be most easily assessed by people, and that is, but it's not the only one, and I want to emphasize that, is what is the young adult doing with their life? What are they actually doing with their life? And here we want to know and we want to assess, are they involved with employment, education, volunteering or training? We're interested not just in what they're doing in those areas, but we're also interested in, are they involved in these activities and taking actions based on their own autonomous values and not simply complying with their parents' values? So we want to assess what are they doing and what are their motives for doing it. And we look to see how they are expressing actions that express competence and self-direction as the primary motivators in their lives. Are they involved in goal setting and initiating steps that are consistent with self-identified values? And we're going to see why values is a very important part of the work that we do with these young adults. Conversely, so that's what emerging adults do. That's how we know they're emerging adults, when they're operating in that kind of way. Conversely, what we see frequently walking in is evaluating what the young adults, primary focus on passive pursuits or escapist entertainment that is inhibiting his or her ability to engage in adult-like challenges. So there it is. And parents often will just focus on what's he doing or she doing or what are they not doing. But we think it's important to look at another quality of emerging adult that is, crucially important, and that is the young adult's relational maturity, right? How are they operating in relationships? There are certain individual and dyadic characteristics that are associated with transition to successful adulthood. So we're looking to see whether or not the young adult is expressing a dynamic balance of autonomy and connectedness to their parents and to their peers. We're assessing and looking at the quality of their interdependence with their parents, in which there's a certain level of healthy dependence. They're not overly dependent and they're not dismissive or isolative. We look and target our interventions to the extent that there's a growing sense, and this becomes a really root metaphor for us, of adult-to-adult interactions, in which there is a hierarchical nature in the family system still, but in a healthy structure, but it's slowly evolving to become more symmetrical over time. And we look to see whether or not the young adult is capable, increasingly capable of an empathic connection to their parents, and not just seeing their parents in their parental roles, but seeing them as adults. These are all parts of growing up emotionally and relationally. So we want to assess those qualities as well as what they are doing. So my background is in drug and alcohol abuse, and so I'm very keen and very tuned into also, obviously, where is the young adult? Are they abusing substances? Because when they are, because as you know, there's incredibly high incidence of substance abuse in this cohort group. And so we're looking to do that because that's going to inform me, as well as some other factors, which I'll state in a second, of who to include in treatment. And if it's a drug and alcohol issue, primarily, in my opinion, we need to address those issues first, because without addressing those issues first, it's a serious, significant impediment to doing the kind of work that I'm going to be talking about momentarily. Finally, at the individual level, we assess just how severely impaired is the young adult in terms of what can be reasonably expected of the young adult. You know, if they are on the spectrum, for instance, is we have to calibrate our work in terms of launching based on what is a reasonable expectation of this young adult, given, you know, the cards that they were dealt as compared to a neurotypical young adult. But the assessment protocol doesn't just end with looking and assessing the young adult, the child, the IP. We also assess how the parents are functioning as individuals and as a couple. We want to assess their attachment styles and how they're relating on their part of that equation. One of the things that is a hallmark of this population is there's an incredible amount of anxiety and worry amongst the parents. And conversely, you can see another attitude, which is just filled with anger. And very frequently you see a marital schism of, you know, the control, the enabling worried parent and the blaming angry parent. And so we need to assess that and work with that part of this system first, very frequently. And we see how whether the parents are being over accommodating to the kid. Okay, so now let me move to the question, which is, who do we work with? What's the treatment modality that we use? Because I've talked already so far about individuals, about couples, about family systems. How do we make the decision who to work with? Most commonly, as I said in the very beginning of this talk, because I'm really blessed to work in a very tight collaborative group practice, we bifurcate treatment. We almost always bifurcate treatment when these families come in. One of the therapists sees the young adult, another one sees the parents. But that's not always the case. Sometimes I'll just work with the parents. Very frequently, I'll just work with the parents. Sometimes I'll just work with the young adult and nobody is really seeing the parents. So that's pretty rare. Although it becomes problematic, and I have a case right now where it started out with me working with the young adult, and sadly, the family therapist who was working with the parents passed away, and I had a collaborative approach with her. The new family therapist is not collaborative, and in many ways that has been a major difficulty to the treatment. So what we do is, in this, is that decision of who to work with is primarily based on how, quote unquote, how stuck the young adult is to their unfinished adolescent story. If the young adult, I'm going to use narrative language here, is being fully oppressed by that story, fully stuck in it, not really a customer for treatment, involved with drugs and alcohol, working with the parents. And as we go up the continuum, if the young adult is not so fully stuck to it, I may work with the whole family system, or I might do a mix and match approach. And then finally, if the young adult is coming in is not really oppressed too seriously by this story, I might just work with the young adult over time. So that's how the decision is made about who to work with in treatment. All right. So let me now move to the treatment approach and then open it up to questions. I'm sorry if this is going on a little too long. So the approach that we take is to try in the family systems, whether you're working with the individually, mix and match, parents, whatever. We're always trying to change the conversation. That's what we're doing. The problem is the conversation, the shared storyline, pathogenic story of the parents and their kids. And we're shifting it so that we are shifting to more adult to adult relationship and shifting away from an adolescent to adult relationship. And the richer we can make these shifts, the more meaningful and sustainable this developmental progression is going to be. So to this end, we try to bring forward vividly emotions, thoughts, behaviors, intentions, identities, relationships in which the family, the kid, the parents are having influence over their problematic scripts, their pathogenic stories, and creating new developmentally appropriate patterns. And we do this, as I said in the overview, through the deconstructive work and the constructive work. So what I mean by the deconstructive work is the purpose of the deconstructive work is to undermine the manifestations of the pathogenic story. This comes from a postmodern lineage, which starts in literary theory. Like a literary critic, we're seeking to collapse the story on itself so that these manifestations become distant. It's not who this kid wants to be. It's not who they are. It's not who the parents are. And we do this by looking at that the story is the problem. And we work with this population to help the parents and the young adults separate from this problem story. As an example, you can have the very argumentative young adult come in and to try to develop in their adult-to-adult conversation the storyline of an appreciation that what this young adult is doing is for an altruistic reason, is they are being argumentative because they hold the belief that they need to challenge things about this family that didn't work way back when, that were problematic with the family, and that they would sacrifice their own self on that altar by not moving forward, by being obstreperous and difficult and challenging and argumentative. That is a very different story than what the parents have to start out with. And we look for examples of that and indications of that and emotions of that to sort of try to separate it away. Or if you read, going back to 1980, Jay Haley, family therapist, wrote this seminal book on leaving home, right? In which he was talking about how the kid was hobbling themselves in order to deflect attention from the marital discord, right? Now, Haley believed that the kid was doing this to maintain homeostasis, and we believe that they're doing it for mastery purposes, but there's another example of that. And in order to do this, in order to help these families move forward, working with the parents now I'm talking about, is that we use a phrase, which is we help the parents think like a therapist and act like a parent. That's a phrase that we'll use. Think like a therapist, act like a parent. And we find that we get a lot of mileage out of that phrase for a couple of reasons. It has an anchoring effect for the parents. It gives them a sense of they're doing something that is aligning with, parents want to be helpful. They don't want to abandon their kids, right? They want to help their kids, and this gives them a way to be of help to their kids. And primarily what it does, it helps them redefine that their way of being helpful to the kids is not based on control. That is so much part of these family systems. It's about control and resisting control and counter control. And that's the pathogenic story. That's the unfinished adolescent adult conversation. It's just replete with control. And when we get the parents to think like a therapist and act like a parent, what they are doing is they're finding a different way to relate. We're helping them create empathy and narrative empathy for their young adult child. They can look at what is, how their presence can be helpful in that kind of way. and they can help them understand their kids in a different way and engage with them in a different way. And they begin to formulate their kids' behaviors as coming from their kids' pathogenic stories, and that they're tests, that their kids are involved with tests, just like we would be if we were doing control mastery therapy with an individual client. When you're doing this kind of therapy, you're always asking yourself, what's the test? What is pro-plan? How will I pass the test here, right? And you don't know. You don't always know, and it's very case specific. But what you're doing is you're gendering hypotheses. For instance, in these kind of cases, the test may be is that the young adult child believes that they have to be the object of worry. So they act in ways that are in compliance in accordance with being the object of worry. But if the parents are thinking like a therapist and acting like a parent, they're going to be, what would be the test here? Oh, well, maybe the test here is not to focus so much on what I'm worried about, but to focus more on also what I admire about this kid. Maybe that will help this kid disabuse the notion of their story that I have to be an object of worry to help my family out here. Or maybe the test is going to be that the kid doesn't believe that they are entitled to a rich, autonomous life, a full life on their own. And they're enacting a passive into active test. And they're saying, hey, parents, do you think you're entitled to a life of your own? And the parents who are operating in ways which are just accommodating and revolving their whole life around their kid has gotten sucked into the vortex of their kid's difficulties, begin to say, if I'm thinking like a therapist, what might pass this kid's test? Oh, maybe we need to start doing things as a couple more often. Maybe we need to start demonstrating that we feel entitled to a life of our own. That might pass the test. Again, these parents won't know, we don't know as therapists, they're hypotheses. And then we look to see what's the response? How is it working, right? Where is it moving the conversation closer and closer to adult interactions? So this deconstruction is occurring in therapy by changing these stories to stories about narratives, hidden loyalty, and altruism. And we frequently do this by asking questions. If you were to do a videotape of my therapy session, you would see I ask a lot of questions. My questions are interventions. And they are interventions because in these kind of systems, maybe all systems, I don't think it promotes adult launching by being the expert that has all the answers. I interpret, I'll throw out a good interpretation. I like a good interpretation as much as the next guy. But I really do believe that when I'm asking questions, it is creating in these clients a sense of their own authorial voice, right? They are coming up with the answers for themselves. And that is what I want to promote, is that kind of movement forward. So the deconstructive work of the content is separating the content into these other themes of altruism, redemption, loyalty, nobility. The second kind of deconstructive work that we'll do is deconstructing context. And this is primarily deconstructing culture and deconstructing intergenerational processes. And when we deconstruct culture, we're looking at how the culture is having an effect on the person and whether it's important to stand up to the culture. And I'll give you an example from my own very personal life. I have a young adult child. He's 24 years old, and he has very severe dyslexia and ADHD. And in my world out here in Silicon Valley, as I said a moment ago, it promotes a great deal of parental shame that my kid is not going to college, okay? My kid is not able or interested or motivated to do that. That shame is coming both from, my own personal background and becoming a PhD, but it's also coming from my culture as well. And if I am succumbing to that, if I don't deconstruct that, as I've tried to do over time, I am going to be operating out of that. And all that will do, what that has done and has had negative effects, is just going to make me more controlling, right? But if I make the culture the culprit, if I stand up to the culture and I say the measure of a human being is not their SAT scores or what school they go to, but there's other qualities that my son has of kindness and being an amazing boyfriend and those kind of things, is, I want to stand up to that. I want to separate and deconstruct from this inherent story that I and he and my wife have been oppressed by. So there's an example of deconstructing culture. Or if you work with clients from cultures other than your own culture. I've worked with clients from Asian cultures. I don't have an insider's view of an Asian culture. But I know from textbooks, there's differences about emphasis on collectivism versus individuality. And my job is to help this young adult author her own voice in how is she going to navigate that in this culture this bicultural reality that she lives in. So in that sense, I'm deconstructing culture. And then lastly, we deconstruct multi-generational transmission. And this is, parents are going to be burdened by their own pathogenic stories. It's going to include their ability to be able to see beyond, the projection of that onto their kids, and helping them look at those intergenerational legacies is going to be important too. I'll give you a case example here. This is a mix and match case where I've worked with the dad and I've worked with the dad and the young adult together. And this dad is divorced. And when I work with him and his son, this dad is so anxious, so worried that he cannot get off. And his son, by the way, spends an enormous amount of time in his room. He's on the internet all the time. He's quite depressed. He expresses suicidal ideation. He's never made an attempt. The most serious attempt he made was by trying to drown himself in the kitchen sink. So wouldn't call that a serious attempt. So I don't really see that he is at risk for suicide, this kid, but he is clearly depressed. And this dad just cannot get off of creating more narrative attunement to him. And no matter what I've done, it's been really hard. He just keeps going back to that. And the kid is showing a lot of relational immaturity. And I'm trying to promote that. And then he's also incredibly intellectually curious and trying to promote that. As you'll see in a second, we talk about the constructive work. This dad is stuck. And it helps them to break out with the dad and find out and understand that, his dad was highly demanding, highly controlling, was literally, pugilistic. My client became a boxer and has this sense of, these very traditional definitions of masculinity and what it means to be a man in our culture. And his son doesn't conform to any of those. And so helping this dad learn how to address his own pathogenic stories has been crucial in freeing him up to be able to do this other kind of work. So making the clubhouse turn here, the work is what we call the constructive work of psychotherapy. The young adult is a complex interplay of elements that are emerging adult and unfinished adolescent. It's not just one or the other, okay? You can see it in different places. And our job, I believe, is to look for in narrative therapy, we talk about it as the sparkling moments, the exceptions of how to how to see when the young adult is operating in ways that are consistent with being an emerging adult, and to try to enrich that story through conversations, through adult to adult conversations, how to promote that more and more through questions. How did you do that? Where's that going to go? Just many, many questions. It really is quite creative in questioning. So we do this by promoting these adult to adult interactions. And then we do it by I use a whole other group of tools in my tool bag. I use acceptance and commitment therapy to help parents learn how, and young adults learn how to take a more allowing and accepting, a less controlling attitude towards their unwanted emotional states. There's a wonderful, the Harvard Negotiation Project, which came out a long time ago, is a wonderful book called Difficult Conversations on Negotiating and Problem Solving and helping parents and kids engage in effective adult-to-adult problem solving and negotiating. I use internal family systems, both with the individual and letting them inform me in the external family system. All of those are being used to help this constructive work towards the lines of more and more evidence of these adult-to-adult interactions. Having said that, it would be nice if all of this moved along swimmingly and everybody, passed through and was a success story. But as we all know, it doesn't work that way. And so I guess the last thing that I want to talk about here is having the young adult leave home, and more generally about limits and boundaries. So our work, the key phrase in this is that we are looking to help the parents move away from setting limits and move them more towards establishing their own boundaries as individuals and as a couple. And so it is a move away from control, and it's a modeling of their own integrity and the right to have an empty nest, a right to have a life, a right to do those things. And out of that is how they express it to the young adult. And I think it's almost always helpful, if it's not for economic reasons, to help the young adult move out of the house. And the way that we do that could be another hour here, honestly, because it requires a kind of process, the process that we've talked about. It's not just about you're out of here in 2 months. It's doing all of this work that we've discussed so that it leads up to the young adult is asked to leave, either because they are not able to live as good co-residents, or because they want to. And so, just so aware of time, and maybe I'll take this as a question. We work in a process of how to move the young adults out of the house. I'm going to stop there because I see we only have about 10 or 15 minutes left, and I do want to invite some discussion. I think that's right. Is that right, Bryn?
Yes, that's what we expect, is that we'll wrap up at 7:30, which is in about 10 or 11 minutes. Robert, I really appreciate listening to an experienced clinician talk theory into action, and you're just as thought-provoking and engaging a speaker as we had hoped. I think our audience of fellow therapists, clinicians, and treatment providers join me in being appreciative and grateful for such a clear and clinically rich address. Thank you very much.
Thank you. Any questions or comments?
Well, I noticed the chat has been very quiet, so
Okay.
I'm going to give people a moment to unmute and throw out a question. But while people are doing that, I have a question. You had used the phrase a couple of different times about passing the test. And I found myself at first understanding it probably the opposite of how you're using it. And then later in the talk, I realized, oh, I had flipped it. That what the adolescent / emerging adult is invested in is having significant others, in a sense, disprove their more pathogenic, pathological predictions and beliefs. And when parents or therapists pass the test, they actually act in ways that the adolescence model does not predict. Is that right?
That's correct. And we will go, I'll even add another word that we use is that along lines of passing tests is I, as a therapist, and ask the parents to see that the kids are coaching them on how to pass the test, right? We believe that the kids want them to pass a test, are coaching them on how to pass a test. And you're absolutely correct about that. Passing the test is disabusing them of these ideas, beliefs, attitudes, which are consistent, which I need to stay stuck as an adolescent, right? I don't have to do that.
Mm-hmm. Thank you.
Robert,
I have a question. Sorry.
Can I add to your question, Ben? Robert, would you say that your experience is that whereas there may be a hope that the therapist, the parents, the adult world will pass the test, that there's also an ambivalence about that, because once that has occurred, ownership of the troubles and the challenges of moving out of them gets relocated within the emerging adult in a way that they've really been, frightened of, or have all their swirl of difficult feeling. So our experience is that they're deeply ambivalent about it.
So this would be a good discussion. No, no, don't understand that they are deeply ambivalent. Okay, the idea but let me, having said that, so starkly, is that calling on IFS language here, there are parts of them that are concerned about that feel scared about that. But if we help move these young adults more fully into a state of self, then what they carry with them is, I think, what we all carry with us. It's not that we don't have misgivings or fears or concerns or stresses about responsibility, but when we are more fully in a grounded sense of self, we have a sense of like, you know what? I can meet that challenge. I can meet my anxiety. I can meet my fear. I can meet all of those things. It's okay to be anxious. It's okay to feel stressed out. I can meet it with it. And this is where some of the act work comes in. So that part from that self is not ambivalent about it, right? But there are, yes, parts that do carry senses of like, oh, now it's all on me. I don't know if I can do it.
Being able to move forward with mixed feelings is really what adulthood's about.
Exactly, right? So maybe ambivalence, yes, they do have ambivalence, but it doesn't function to impede their progress in life, in a significant way. I mean, it does for all of us, I think, to some degree, different times, but not in a significant way.
We have a question from the chat. Really appreciate your rich clinical insights. You mentioned 3 types of stories family members tell each other. The first is pathogenic stories. What are the other 2?
Oh, okay. So those stories are the unfinished adolescent to adult story and the adult to adult story.
The 2 adult story?
So the one story is, I'm a teenager, you're parents of a teenager. You're a teenager, I'm a parent of a teenager. That's a story. Okay. And another story is, I'm an adult.
Oh, I see.
Of an adult. Oh, I'm an adult and you're the child of an adult. And you're an adult, right?
Right. Got it.
The adult to adult story, the unfinished adolescent to adult story, pathogenic story.
Got it. Thank you. Other questions? Feel free to unmute yourself, or you can put it in the chat. While people are pondering the opportunity, Robert, can you say more about the kinds of questions you ask to deconstruct the narrative? You say you ask a lot of questions. I'm guessing you might have a storehouse of useful kinds of questions. I'm inviting you to share a few examples of your
Okay,
favorites.
I will, but let me go back to the last question.
Please.
Because I think that was what I said is true, but there's another way of also slicing and dicing that.
Okay.
So pathogenic story, which is anti-plan, and then there's the two pro-plan stories, which is deconstructing the content and culture context. That's a story. It's a pro-plan story, but it's separating the person from the problem. And then there's the third story, which is the constructive story, which is how am I showing up in these ways that are consistent with being an adult to adult relationship. So just wanted to clarify that.
Got it. Thank you.
I had written down here, but I was going pretty quickly about some questions that I had asked a mom. Let's see if I can find it here quickly. Give me a moment, will ya?
Okay.
So this was a case example where I was working with a recently widowed mother of a 21-year-old who she views as lazy and self-indulgent.
Mm-hmm.
Began to collapse this pathogenic story as she looks at his separation guilt, his worry about her, maybe compliance to her unwitting message that she needs him to underfunction to give her life purpose. And so here are some of the questions to the mom. How do you stand up to worry? Worry clearly causes distress, but what is it intending to accomplish? What would be the danger of lessening worry? And I could just go on and on with that. Right?
Yeah, it strikes me that the family therapy literature is replete with these kinds of questions, particularly from the structural strategic schools. I even hear echoes of the circular questioning of the Italian family therapy school.
Exactly. Carl Tom and all of those. I mean, that's what I grew up with. That was my training, was in that kind of family therapy. And it's also very much consistent with narrative therapy too. It's
right.
What are the, just some narrative questions. What are some of the resources you would call on? What are, who would notice to a kid? Who would notice first in your family that you were taking more responsibility? That's a narrative therapy question.
Yes.
Right.
Yes.
And all of those questions are, bringing forward these narratives.
Right. State that. Well, I do think your talk was wonderfully clear, really well illustrated with clinically cogent examples, and that might explain, as well as the lateness of the hour for many of us here in the Midwest who have had a long work day under our belts before even we started tonight. That might explain why there are not more questions. I would take that as a compliment.
I've given a lot of talks in my days to players, and I don't know, maybe it's me. I just don't get a lot of questions. So I don't know what that's about, but I will finish up by saying I really appreciate the opportunity to be able to share this with all of you. I've been doing this, like I said, we created we began working on this model, 13, 14 years ago. It's been a really big part of my clinical practice. It's been
It
really
shows.
for me. And I am, I'm grateful to be able to share with all of you.
As are we. We thank you so much for your generosity and giving us your time and your experience. I see we have another comment. As a grad student who really likes internal family systems theory, I appreciate your additions to the literature.
Well, I appreciate that too. And I guess I'll say, I'm just starting to learn internal family IFS. I mean, I'm into it. And, I hope that it's definitely true for me. Even at this stage in my career, it's like, I just want to add, because I'm pretty stoked about IFS and using it more and more in my work with this population. I would have never even talked about that even 3 years ago. So,
There's something to be said for cultivating a beginner's mind in our field, and I think
Exactly.
you've inspired us to do just that.
exactly.
Well, it
Thank you
parallels
so
what you described about what happens inside your own group. Collaboration among the different perspectives in the field.
Yeah, exactly.
Great.
Thank you,
Appreciate
Robert.
everybody's attention. Have a good evening.
Look forward to a continued relationship with you.
Thank you, you too.
Be well.
Good night.